small incision. And as we discussed in our surgery, or we'll discuss in our surgery, I like to make what's called an envelope reflection. I'm not making any vertical incisions. We have a mucogingival line, so we have attached gingiva, and I don't want to incise into the mucosa. If we incise in the mucosa, then we have prostaglandin and histamine release, and the patients will be uncomfortable. So what I'm simply going to do is very gingerly see if there's any defect where there was an infection there. And I need to elevate that tissue so that I can see any facial defect. And you can see the facial plate of bone is pretty much there. So we don't have a big defect there. And I'll do the same thing on the palatal aspect. Very good. And now we'll go to our implant placement. Positioning. So to graft this site, I'm going to use a material called Osteogen. It's a calcium apatite material in a bovine Achilles tendon matrix. This is how it's packaged. It comes in a small or narrow and a wide, and it has consistency to it. It's firm. This is not a collagen plug. And what it'll do, it'll absorb the heme in the socket site. We're going to place this Osteogen plug into the socket site prior to implant placement. And if we do this really slowly, you can see how the blood absorbs right into it. And I'm going to place this firmly without crushing it into the defect. So this is almost like caulking, where it's going to fill the void. Now, you would think I just filled the osteotomy that we did. However, this material is such that I'm able to thread the implant right through it. It'll be pushed along the sides of the walls of the socket. I'm going to site, and I'm just going to hand tighten. You can see, because we didn't make any vertical incisions, the closure is really simple. And we wouldn't necessarily have to do it in this situation, but I wanted to demonstrate it. Is I took that Osteogen and I made a manhole cover, and I kind of squished it with my fingers. And if we had a smoker or we had a bigger defect, I could simply place this to cover the implant to allow the epithelium to grow on top. And again, if you have a smoker, we have to protect the site as much as possible. Would have to do it in this situation? No, because we don't have a smoker, but I just wanted to demonstrate it. Then I will simply squeeze hard. We have a good facial plate. We have a band of attached gingiva, and I'm just going to do a couple nice sutures here, and we are basically done with our patient. I'll come from crestal to facial. Hold this here. And then I'll go from crest to palatal. And then I'll go 2 forward. And you only pull one end. And going 2 forward again is going to bring that knot into position, and then 1 backwards will lock that into position. So here I was able to place 3 sutures to close the space. I protected the implant. Epithelium will grow 0.5 millimeter to 1 millimeter a day. I don't expect primary closure in this situation, but that's okay. I like to see my patients in 7 to 10 days. By that time, the site is almost completely closed over, and we'll have a healthy situation for the future.